Let's study about the amoebiasis, which is also called the amoebic dysentery. Amoebiasis is an infection which is caused by the protozoa Entamoeba histolytica and includes amoebic colitis and amoebic liver abscess. It is caused by the Entamoeba histolytica. For the transmission, primarily it is transmitted by the foodborne exposure, which is ingested by uncooked food contaminated by human feces. Primarily, it is transmitted through the fecal-oral route. It can also get transmitted through the contaminated water, oral and anal sexual practices, and direct rectal inoculation through colonic irrigation devices. Amoebic dysentery is common in developing countries, homosexual males, in the immunosuppressed individuals, in the institutionalized persons. On pathogenesis, the organism Entamoeba histolytica exists both as a motile trophozoite form and the cystic form, which is the infective form that can survive outside the body. Cysts are transmitted by ingestion of contaminated food or water or spread directly by person-to-person contact. Trophozoites emerge from the cyst in the small intestine and then pass on to the colon where they multiply. Cysts invade the mucous membrane of the large bowel. Maximum lesions are present in the cecum. Flask-shaped ulcers surrounded by the healthy mucosa is seen. This is how Entamoeba histolytica, there is two phase, which is the cyst and the trophozoite. Cyst is the infective form which is ingested by the human through the fecal-oral route. Then it reaches the esophagus, then it reaches the stomach. Then this cyst, each cyst gives rise to the 8 trophozoites which reach the small intestine. Here trophozoites divide by cell division. In the large intestine, the trophozoites give rise to the cyst, which is called encystment. Then there is formation of immature cyst, then mature cyst, which is excreted through the stool, and as cyst is the infective form, it can infect the other individuals. This trophozoites effect has also extra-intestinal invasion, like it invade from the intestine, it invade the lungs where it causes the lung abscess, it invade the liver where it's called the it invade the liver where it forms the liver abscess, it invade the lung where it causes the lung abscess, which is rare, and it infects the brain where it causes the brain abscess. On clinical features, incubation period is from 2 weeks to many years. In amoebic dysentery, there is grumbling abdominal pain and there is 2 or more unformed stools per day, and the stool is mixed with mucus or sometimes it streaks of blood. Stool is often offensive in order. There is history of diarrhea alternating with constipation. As the course is long-standing patients, there may be history of weight loss due to continuous diarrhea. In elderly patients, there will be acute symptoms with frequent motions with passage of much mucus and the blood. On signs, doctors can see the fever, weight loss, diffuse abdominal tenderness, and tenderness along the colon, especially cecum and the pelvic colon. For the diagnosis, we do the routine and microscopic examination of the stool, where in the stool we can see the motile trophozoites containing RBCs, which is considered as diagnostic. We can also do the sigmoidoscopy, where we can see the flask-shaped ulcers, which should be scraped and examined. Anti-amoebic antibodies can be detected by the immunofluorescence. Antibodies persist for years after the initial infection. We can also do the PCR and DNA probes in the stool. Complications of amoebic dysentery is that There will be toxic dilatation of the colon. It can lead to amoebic liver abscess, chronic infection with stricture formation. It can lead to severe hemorrhage. There will be formation of amoebema, which is the localized granuloma present as palpable mass in the rectum, or in radiography we can see it as the filling defect in the colon. It can also cause perforation. For the management, we give the azole like the metronidazole 800 mg per oral 8 hourly for 5 days, and tinidazole 2 gram per oral daily for 3 days, plus diloxanide furoate 500 mg per oral TDS for 10 days for elimination of the luminal cyst. For the prevention, as amoebiasis is difficult to eradicate because of substantial human reservoir of infection, so the only progress will be through improved standards of hygiene and better access to clean water, and cysts are destroyed by boiling, but chlorine and iodine sterilizing tablets are not always effective. So in amoebic dysentery, we see the definition, which is the infection caused by the protozoa Entamoeba histolytica, which includes the amoebic colitis and amoebic liver abscess. And for the transmission, it primarily transmits through the fecal-oral route by the contaminated food by the human feces. It is common in developing countries, homosexual males, immunosuppressed individuals, and the institutionalized persons. On the pathogenesis, the person ingests the infected cyst through food and water. Then it reaches the stomach. From there, it reaches the small intestine, where it forms the trophozoites, and in the large intestine trophozoites attach and forms the cyst, which gets mature, and most cysts came out of the stool and infect the other person, and the other trophozoites can invade the liver, where it can cause the liver abscess, lung, where it can cause the lung abscess, or the brain, where it can cause the brain abscess. On the clinical features, the patient presents with the grumbling abdominal pain and 2 or more unformed stools per day, and the stool is often mixed with the mucus and the streaks of blood. Stool is offensive in odor. There is history of diarrhea alternating with constipation. As the course is long-standing, patients may present with history of weight loss. Elderly, acute symptoms with frequent motions with passage of much mucus and the blood. In the old people, there is more passes of the mucus and the blood. What we see is the patient is febrile, there is the weight loss, there is the diffuse abdominal tenderness and tenderness along the colon, especially cecum and the pelvic colon. For the diagnosis, we examine the stool, routine examination, and the microscopic examination, where we see the motile trophozoites which contain RBC, which is the diagnostic. On sigmoidoscopy, we can see the flask-shaped ulcer, which can be scraped and examined. Anti-amoebic antibodies detectable by immunofluorescence. We can also do the immunofluorescence, in which we can see the anti-amoebic antibodies, as antibodies persist for years after the initial infection. We can also do the PCR and DNA probes. In complications, we see that it causes the toxic dilatation of the colon, it can cause the amoebic liver abscess, it can cause chronic infection with stricture formation, can cause severe hemorrhage, amoeboma can form, which is the granuloma, as present in the rectum as a palpable mass, and in radiography we can see this as the filling defect in the colon. It can also cause perforation. For the management, we give the metronidazole, tinidazole plus diloxanide furoate. For the prevention, it is difficult to eradicate, but we can prevent it by maintaining the hygiene, drinking the clean water, and by boiling the water. So this is all about the amoebic dysentery. Thank you. You can find these notes on the Telegram, and links are given in the description.